bonus question, and then the answer to the question will get one of the Maestro ties. Or scarves.
Let's see. What question would you like to ask? So we started the morning half really with more of a science kind of discussion and some introduction to the background for TH302. And again, hopefully one of the reasons for your interest in participation in Maestro really is because of the need in pancreas cancer and then also the mechanism of action of the study drug. Let's talk about another case. And again, it's hopefully somewhat similar to cases that you've seen in your practice. 57-year-old patient with a ECOG performance status of 1, is employed as a house painter. He has some weight loss and abdominal pain, 6 kilos of weight loss in 8 weeks. Type 2 diabetes diagnosed 6 months ago. He sees a primary physician and has elevated AST, alk-phos, and a normal bilirubin. Has an ultrasound to evaluate his symptoms, and there is a mass in the head of the pancreas identified. No obvious liver metastases, no ascites. He has a spiral CT scan of the abdomen. There is a mass in the head of the pancreas. There's some vascular invasion, no distant mets, and CA19-9 is elevated. And so just at this point, some questions, let's just define or to see at your different location, what defines or who defines resectable pancreas cancer? And in Hungary, at your location, what is the definition or how are patients evaluated for resectability of their pancreas cancer?
It is a good question, but I don't tell you exactly because I'm not a surgeon.
So the surgeon,
Yes.
is this in a tumor board or is this,
yes.
Okay.
And I think in this case we don't know the histological situation.
Oh, yes, okay. Yeah, does the patient have cancer is what you're asking, first of all, yes. Yeah. This vascular invasion, and what we have heard again from many different sites, is the definition of resectability is very dependent on the surgeon. We have heard this. Certainly some surgeons are very aggressive and can say, I can go after everything, and other surgeons more conservative, or still some sites are very selective and follow, for instance, the criteria regarding how much vascular invasion is present. At your location, is that tends to be?
We have the pancreatic surgeons, so we have a multidisciplinary approach, and we discuss every case, every patient with all together.
Yeah.
And then with the radiologist, the encasement, the involvement of the arterial,
vascular
the vascular
involvement
invasion. Yes,
yeah.
you're right.
And
But we are lucky because we have surgeons dedicated only for pancreatic cancer. We have a lot of surgeons that could follow the patients, but in particular, we have pancreatic surgeons.
Okay. So let's, for sake of discussion, let's say the patient has confirmed pancreatic malignancy and has this presentation of, I didn't say how much vascular involvement there is, but again, this vascular involvement. At this point, is this someone who is even on any radar screen for like the Maestro study? In terms of if they're not resectable, that's possible as an option, or if they are resectable, then they would go to surgery, or is this too early in the presentation where you would even think of Maestro for if the patient is not resectable? Dr. Salim, do you know in your group how that works? Or?
I mean, it will cross my mind really in a multidisciplinary meeting where we discuss like you do, where the surgeon, the radiologist also are there, And
It would come up at conference?
yeah, at the multidisciplinary. I mean, we will say if it is unresectable, we will see. We may consider them for mastro at that point. But it all depends on when we see the patient, look at the performance status, need to reassess and other things.
Of course, performance status comes in there.
Yeah.
And of course, all the other criteria for meeting the trial eligibility. What's the role of preoperative therapy at your institutions? Dr. Accrual, do you want to maybe help us understand
What do you
that?
mean by preoperative therapy?
You tell me, what does that mean? Or help us understand,
my
in
opinion,
your mind, what that means.
Preoperative therapy is for resectable disease. This is
Resectable.
yes.
Okay.
It is neoadjuvant chemotherapy. Conversion chemotherapy could be applied here because the patient has a clearly unresectable disease. It's, if you have an infiltration, a vascular infiltration, it is a stage 3 disease, and I will do my very best not to let the surgeon go for it.
Are you successful?
Sometimes. I think that literature says that the chance to radically resect a patient who is initially unresectable is 10 to 15%.
So at your location, that is not an approach normally where you're giving what you're calling
not
conversion
easily.
treatment. Okay.
Even if I consider that that this patient is not the optimal candidate for the trial. It
Not?
could be
Okay.
no.
Why? And the
It
reason
could be
for that
could
is-
be offered the trial, but it's not. Well, because
What else are you looking for in a patient?
well, because I consider the optimal candidate not a man with 57 years, no comorbidities, and borderline resectable or unresectable disease. I offer the trial most of the times to clearly metastatic patients.
To overt metastatic
Yeah.
disease, not a locally advanced unresectable.
Locally advanced is a little bit different. They have a different prognosis too. The radiotherapy could be useful. How to integrate this in the trial?
Okay. Any thoughts? How about Dr. Zelinsky at your site? What is a patient? How is a patient like this?
I think if surgeons decide that this tumor is unresectable, we would try to treat by radiochemotherapy as neoadjuvant.
Neoadjuvant meaning to shrink to go to surgery ultimately again or to try again?
Yes.
Okay. So an approach to perhaps make a patient more of that 10 or 15% that could have resection. How about?
But I think this case, a really pancreatic surgeon, a really good pancreatic surgeon will be made operation.
I'm sorry, would do an operation? You think a true pancreas surgeon would explore the patient?
Yes.
Okay. So interesting comments because, again, everyone is a little different in how your center defines things for one. So clearly, locally advanced unresectable is a little bit of a moving target. Some patients are clearly unresectable. Other patients are in this gray area, and maybe let's try something to make them maybe more resectable. And other patients are surgical candidates up front with a good surgeon. But let's move on this case. So this case was reviewed at Tumor Conference, and he's defined as having one of these borderline unresectable, not overtly unresectable, not let's take him to the operating room now. So he gets preoperative 5-FU-based chemoradiotherapy. I know chemoradiotherapy in Europe is not as common. Correct? It's usually chemotherapy, then a sequential radiation or chemoradiation approach. Is that right?
Yeah. If we consider neoadjuvant treatment as a definition, we have to start together chemo and radiation therapy. The problem in our center, maybe in all Italy, is the radiotherapists are not are every time they are late, and so we have to start with chemotherapy and then we can go together.
Okay.
Maybe
So
there is a
They
it's a
jump
very,
in
yes,
the radiation.
yeah, so we for rectal cancer, for other type of cancer, we can stay with a real neoadjuvant
Yeah.
concurrent chemoradiotherapy.
Okay.
But it's quite difficult in this type of
More
patients.
of a scheduling issue. So the patient gets this combination 5-FU-based chemoradiation therapy, and he completes that. CA-19-9 comes down. But within 5 weeks of completing this treatment, he has new metastatic disease. So the intent was to go to surgery, but now he has new metastatic lesions. I think we discussed this question, which was borderline resectable versus unresectable. So let's just consider this second question. Is this a patient now where a clinical trial for metastatic disease could be considered in this setting? Would this be a patient that would be a type of case that you would consider for a trial like Maestro or a first-line metastatic study? Dr. Bukowski, any comments or in your experience?
I think it could be considered.
Could be considered. Would you consider Maestro as an option for this patient?
I think about two possibilities, I think, for this patient in our country. First is Maestro, and the second is FOLFIRINOX.
FOLFIRINOX
Yeah.
or Maestro? And what would help you decide between those two options?
Performance status, comorbidities, I think.
So he has an ECOG of 1. His only comorbidity is he has some mild pain. He's lost some weight.
Okay.
But otherwise, he's able to, how about this? So he worked as a house painter.
Yeah.
He's not able to work, but he's able to get around. He walks. He is eating fine. Does this go into your assessment of performance status?
Yes, but the problem is what will be the best option for him, and he's 57-year-old. I would prefer better for him FOLFIRINOX and first option, for me.
Because
of 11 months over survival. And when I have in the back of my mind this result of the study, and
so just a question, because again, the role, if you could do a first-line treatment with multi-agent chemotherapy, but toxicities are significant,
yeah,
or an option perhaps of considering maybe a single agent or doublet treatment, maybe you get a couple months from that, but then additional second-line therapy where you can get 2-3 months from that. Is that beneficial? I guess the question I'm coming to is what diseases in oncology have we seen multi-agent combination chemotherapies actually so superior to sequential single-agent therapies in terms of longevity? And do we need to think about pancreas cancer differently, or do we always think about it as it must be FOLFIRINOX as a combination or nothing? Because you've brought up many times already that toxicities are very significant.
Yeah, I think that it's a wonderful point of view, what you are saying, because sometimes we forget to think about what's going with the patient. If you will live more 3 months with a lot of side effects, instead of 5 months with good life.
Yeah.
So I
thoughts, or do you have?
Because we have a lung metastatic, and we know that lung metastatic is not so.
Yeah. I mean, we know, like in breast cancer, right, many women were treated with multiple agents, combinations,
I don't think that
but we see the solid
I don't
single
think that we
agent
can
therapies.
compare with the
But in
breast
terms of
lung.
just the theoretic understanding or possibility, but any responses to that thought process? Is that, well, that's dumb. That's like, you can't think of it that way in terms of managing pancreas cancer. Any thoughts of this?
I mean, at this time point, the patient could be a good candidate for the trial. You're using a non-cross reactive agent. He probably has an aggressive disease because the disease flare up during chemoradiation. But I mean, gemcitabine plus TH302 is a good choice. So.
Possible.
I'm sorry, the bad guy here
Yeah.
again. First of all, I would like to say that I share fully your thoughts about the general management of patients with cancer, and especially pancreatic cancer. But here, according to the protocol, so this is inclusion criteria number 3, it says that neoadjuvant chemotherapy can have been given to the patient if relapse occurred at least 6 months after surgical resection.
So if he hasn't had surgical resection, where does that fit in the protocol eligibility?
So so patients in general could not have had neoadjuvant chemotherapy. They can have only if the relapse. So here in our case is this lung met has occurred at least 6 months after eventual surgical resection. So
Right, so the goal of this, and this is, again, important and useful to review because these are cases that do come up clinically. So this is a case, a patient who had essentially local disease, had 5-FU gemcitabine, 5-FU-based chemoradiation therapy, was going to have surgery, didn't get there because developed metastases within 5 weeks. So how do the sites interpret eligibility on this kind of case? And I think it's great, Konstantin, that you're here because that's the important part of.
no, I agree. The protocol is not completely clear, and that's why we are all sitting here.
Yeah.
Because there is another exclusion criteria only concerning radiotherapy, which says that the radiotherapy. I'm sorry, let me move the page.
So 28 days, I believe, 4 weeks.
To the so it was 28 days as well,
So
but
this
it's
guy's 5 weeks.
prior to the date of randomization, so it's different.
Yeah.
I slightly disagree with you. I'm sorry, but in the inclusion criteria number 3.
Yes, and this is good that you disagree because it's true. It considers patients who have had successful operation.
Okay, but
So you're right.
You read that
You can get 5-FU without.
you have to wait 6 months only if the radiosensitizing would be gemcitabine,
Right.
not 5-FU.
You can get 5-FU and a combination with the 5-FU and X-ray.
So if it's
I'm actually hoping to
gemcitabine-based-
clarify some of this in the
Yeah.
next presentation.
Yeah. Oh,
So,
okay,
yeah,
great. Okay.
I'll try.
So that's a good lead-in then to Bruce and, so that's a good lead-in. But this is the kind of discussion and clarity that I think is important that comes out in these meetings because each of you interprets the protocol and we all think about the protocol differently. But obviously the sponsor has specific intent and goals of what types of patients are of interest to enroll to the study. So let's leave this question, and Bruce, then do you want to?
My time?
Yeah.
Okay.
And then we can come back for some clarity on how we want to answer this.
All right. So I joke with Mark all the time because I think this is, the 12th accrual workshop that we've done now? 11 or 12 in the US and Canada and now in Europe. And I guess Mark saw me sitting here too many times, not working hard enough. So he's this very smart man. He put me back to work. I hired him, but he put me back to work. So
Bruce, it's much more impactful.
but of course, you don't want to hear the same people talk. So we'll mix it up a little bit. So I thought maybe we'd start off with something maybe not so scientifically deep. And talk a little bit about the branding of the study. You probably saw that we all have these ties or scarves on. And when we set this trial up, we really wanted to kind of set it apart, right? So that when you hear somebody mention Maestro, you think of TH302 in pancreatic cancer. You don't think of the EMR 200592-001 study, right? So now, you know, if you hear Maestro, you know it's TH302 pancreatic, okay? But who knows what Maestro stands for? It's a quiz question. Okay. So I have to have a slide because I can never remember this myself, and I actually helped come up with the acronym. And it's amazing what these computer programs will do for you these days when you type in large protocol names and what they'll spit out. But this is what it spit out: evaluating TH302 in the treatment of M, metastatic, and locally A, advanced, unresectable ES, pancreatic T, adenocarcinoma RO. That's how we get Maestro, okay? Little trivia: somebody asked you when you get back to the office where Maestro, what it stands for, now you know, okay? The other thing is, you probably saw this, we have a little, oops, uh-oh. What did I do? You probably see the little doohickey thing. We call it a swoosh. Right here. Is there a pointer on this? The top one, okay. So right here, this is what we call the swoosh. And again, that's supposed to be the little branding that of a conductor conducting an orchestra, right? So that's the Maestro, okay? All right, enough of that. We'll get into the science now. Back to the science. All right, so I'm going to spend a few minutes just covering some of the key inclusion and exclusion criteria for the protocol and the objectives of the study, okay? I'm sure you're all very familiar with it. You've read the protocol, so I'm not going to belabor it, but we'll just step through it quickly and maybe hopefully try to clarify some of the questions. All right? So primary objective is to evaluate overall survival for efficacy, comparing gemcitabine in combination with TH302 versus TH302 with placebo. Gemcitabine, sorry, with placebo. In previously untreated, locally advanced, unresectable, and metastatic pancreatic carcinoma. Okay, so this is something that's a little bit different. For the Celgene Abraxane, Gemabraxane product, that's just for metastatic. Okay, this study here takes both metastatic and locally advanced. Some of our secondary objectives are to continue to look at efficacy with respect to looking at progression-free survival, objective response, as well as disease control. We're also going to be evaluating patient-reported outcomes for quality of life. We have 2 quality of life measurements or questionnaires. The EORTC QLQ-C30 and the EQ-5D-5L. Maybe they should come up with some acronyms for these. Might help. As well as evaluating pain by using a numeric pain scale, okay? And then, of course, with all clinical studies, we want to look at safety and tolerability, all right? So that's obviously inherently built in. For investigational objectives, we're going to be looking at the tumor antigen CA19-9, and we did take a look at, Dr. Trojan showed some results on one of his patients on that, so we're going to be wanting to follow that, as well as we measured that in the phase 2 study as well. We're going to be doing some additional PK analyses. You may ask, why are we doing PK in a large global phase 3 trial? It's a little bit late. We did run some of this in the phase 2, but not enough to satisfy the FDA. So we're building upon that database of PK results. We're going to be looking at some pharmacogenetic markers, which require a separate informed consent It's optional. It's highly recommended because we would really like to be able to do those analyses. But again, it's optional with that optional consent. And then lastly, we're going to be looking at biomarkers, predictive markers for hypoxia, and hopefully being able to target something or identify a biomarker that we can use in future studies. Okay? So that's the overall objectives and the thought behind the study. So as far as the design, it's a pretty typical large double-blind placebo-controlled design for a trial like this. Similar design is what we did for the phase 2 trial, okay? Again, we're looking to enroll locally advanced or metastatic pancreatic cancer, 660 patients, randomized 1-to-1, so 330 in the gemcitabine plus TH302 arm, and 330 in the gemcitabine plus placebo arm, okay? And then those patients will also be stratified based on disease, extent of disease, performance status in regionally. Patients will be treated on a monthly cycle, so day 1, 8, 15 of a 28-day cycle monthly. For TH302, they'll be receiving 340 milligram per meter squared over a 30-minute or a minimum of 30-minute infusion time. Patients then wait about 2 hours to 2.5 hours, and then they receive 1,000 milligram per meter squared of gemcitabine. Okay. So as far as our key inclusion criteria, again, locally advanced, unresectable, or metastatic. And again, the locally advanced is something that's a little bit different than the metastatic labeling for gemabraxane. And this is hopefully what we'll try to clarify. Now, this third bullet, previously untreated with chemotherapy. The reason the protocol was written this way, and it is a little bit confusing, is so that we can try to include as many patients as possible. We want to try to limit the number of patients that we have to exclude. All right, and we did get some feedback actually, because the title does say previously untreated. That does create some confusion because people are thinking, well, right off the bat, if my patient has had some kind of treatment, they're not eligible for this trial. It's not true because of all of these other thans. So the first one is patients can receive radiosensitizing doses of 5-FU. There's no time requirement around that, okay? Second one is radiosensitizing doses of gemcitabine if relapse occurred at least 6 months after they completed the gemcitabine. The third other than is neoadjuvant chemotherapy if relapse occurred at least 6 months after the surgery. And then the fourth one is adjuvant chemotherapy if relapse occurred at least 6 months after the completion of the chemotherapy. So it's always 6 months except for the 5-FU, okay? The radiosensitizing 5-FU. Does that clarify a little bit,
So
at least based on the last case?
Yeah, that we just discussed meets all of these criteria
Yep.
and would be eligible.
Based on this, that
for
patient would be
Maestro
eligible.
Eligibility.
Yep.
Okay.
Just to comment, so the idea or the principle behind that is that any patient that would be eligible for gemcitabine mono, that would be eligible for Maestro. And of course, these 6-month definitions come from the idea that if a patient has relapsed shorter than 6 months after having received gemcitabine, then the patient probably is resistant to gemcitabine. That's the guiding principle behind that.
Okay, continuing on. Measurable disease or non-measurable disease. Again, written this way so that we're not excluding anybody unnecessarily, okay? Assessed by RESIST, which I'm sure you're all very familiar with RESIST 1.1. A good performance status, ECOG 0 to 1. And again, you know, to your concern, it's written this way because this is how the phase 2 study was written. We want to make sure that we're consistent where this is a registrational trial. We also want the best patients too. We want as healthy as can be so that they're going to do well in the trial. Life expectancy, just going back to the performance status, assessed by 2 observers, okay? They don't have to be both MDs, can be a study coordinator, can be a nurse, but the second observer does need to be on the delegation of authority log with Covance, okay? Life expectancy of at least 3 months, and of course acceptable organ and hematological status, okay? Basic stuff. Exclusion criteria, the key exclusion criteria, because this is a hypoxia-activated targeted therapy, we want to make sure we're not giving it to patients that have chronic obstructive pulmonary disease, all right, that require oxygen. Would not be a good candidate for this type of a trial, all right? Major surgery, other than diagnostic surgery, less than 28 days, right? So if they've had major surgery, but it's 35 days, 3 months, they're still eligible. And then treatment for pancreatic cancer with radiation therapy or surgery, so a Whipple maybe, they've had a Whipple, but as long as it's over 28 days, they're 28 days out, they're still eligible for the trial. These next 3 are safety exclusions required by the FDA. We submitted the protocol for a special protocol assessment through the FDA, so we do have a SPA with this study. But they did ask us to add in these additional safety measures, which I know creates some concern and some challenges for the sites. The first one is subjects who are taking medications that, this is important, that prolong the QT interval and have a chance or a risk of TDP, okay? It's not either or, it's the medications have to cause both, all right? Subjects, there is, in the protocol, there is an appendix that lists out some of these medications, all right? And then the next 2, because TH302 is metabolized through the liver and the cytochrome pathways, these were required, again, for safety reasons. Any medication that is a moderate or strong inhibitor or inducer of CYP3A4, or any medication that is sensitive substrate or substrates with a narrow therapeutic index of the next 3 cytochromes. I won't read them out, but there again, we have an appendix in the protocol. Unfortunately, it's not exhaustive. It's a sampling of medications, so the onus is on the sites and the MDs to make sure that you really understand the medications that your patients are on and really look into this. And then, of course, if we can be of any help, Constantine is available to help you with that, okay? That's the protocol. Are there any questions around the protocol? Any specific challenges that anybody wants to raise or discuss? No? Okay, then I want to just move on talking a little bit about dose intensity. So one of the things that we found on the phase 2 studies, and we're also seeing with some of the Maestro sites, is that a lot of the sites are just, as soon as you see a toxicity, you're going to dose reduce, all right? But because this is a clinical trial, we want to maintain that dose intensity as high as possible so that we can obviously get good results, all right? So when can patients be dose reduced per the protocol? Well, it's pretty clear in the protocol that any patient that complains of a grade 2 intolerable skin toxicity needs to be dose reduced, all right? This is manageable, and we're going to talk a little bit more about the management of that. I think Nora's going to, in her presentation, will talk about it. It's preventable, or at least you can minimize it. Any grade 3 rash, hand-foot reaction, oral mucositis, again, many of these issues are manageable through the skin toxicities. Hematological toxicity with the absolute neutrophil count is less than 1,500 per microliter and platelets less than 100,000 per microliter. Again, we can manage this with the use of colony stimulating factor, okay, per the protocol. And we'll talk a little bit more about that. And what we found is that normally, once the dose is reduced, the sites don't go back up. So that's why it's so important to keep that dose high right from the very beginning. Because once the patient is dose reduced, tendency is never to go back, all right? And again, the impact is we really want to make sure that we have a successful trial by keeping those doses as high as possible. So just some additional guidance because the protocol is not crystal clear on this. Dose re-escalation is allowed for hematological toxicities with the use of GCSF. And this is the section of the protocol that discusses that. So section 6.5.2, GCF may be implemented in subsequent cycles if neutropenia results in a dose reduction or dose delay at prior doses as suggested by the ASCO guidelines, okay? The second bullet, the protocol does not disallow dose re-escalation for non-hematological toxicities. So essentially, skin reactions, all right? So the protocol essentially remains silent on this. It doesn't say anything about it. But again, if a patient has a grade 2 intolerable skin toxicity and you dose reduce, you're not going to go back up, typically, all right? So again, we want to minimize that. It's not required in the protocol, but if you have any questions around this or you're considering a dose reduction and it's not an emergency situation, please contact Covance and Constantine. They'll be happy to discuss the issue with you and walk you through it, because in many cases it can be managed without the dose reduction, okay? And I think that's it. I think I'm going to just finish up with just briefly talking about high-level safety overview on this. The majority of what we see for safety for patients is mucositis, stomatitis, again, preventable with the use of the patient care directions. Chewing on ice goes a long way. The recommendation is to start the patients chewing on ice before the infusion starts, during the infusion, and about 15 minutes after. And it makes a huge difference in preventing the mucositis. We also see, as you know, a lot of the skin reactions, and I think, Nora, you're going to show some pictures around that, right? Do we have some pictures?
You and we have Nora Boyer's video.
Okay, so we'll be able to show some pictures and talk a little bit about that. Nausea and vomiting associated with other chemotherapy agents like the gemcitabine, again, can be prevented with the use of antiemetics. And then we also see decrease in blood counts, myelosuppression, pancytopenia, neutropenia, the neutropenia with or without sepsis, and sometimes associated with the use of a stent, okay?
What about steroids?
Steroids? Steroids are
Loud.
yeah.
Very
Yep.
good.
Are you using steroids as part of antiemetics or?
Any questions? No?
Great.
Okay,
Thanks.
great. Thanks, Nora.
So a question, maybe Dr. Salim or Dr. Pillay, you can answer how your patients are doing on the study. You have several patients on the study now. Can you tell us your experience? Have you had skin problems, blood count issues?
I think one subject had skin toxicity.
Do you have any details or specifics that you
I
recall?
actually didn't treat the patient
I'm sure,
myself,
yeah.
so I think the information I got was it did resolve following your
With
guidelines.
interventions.
Yes,
Ah,
interventions.
okay.
So it was thing, but otherwise, generally, I think the patients have tolerated well, and I do not think we have had any hematological toxicities as yet.
Oh, that's great. So
So,
the patients,
which is interesting because you seem to have had a lot of thrombocytopenia in the previous thing in the phase 2 study, right?
but yeah, and you're not
How is
seeing,
your
seeing
hematologic
that, huh?
toxicity so far in the study?
The numbers, I don't have them in my mind. There is some grade 3 for neutropenia and also some grade 3 for thrombocytopenia in the combination with gemcitabine, yes. But again, I mean, we are doing here the phase 3, and so that will be the major proof for impact on the bone marrow.
Any experience you'd like to share, Dr. Furman?
Yeah, we have a 71-year-old patient that told me that I haven't so many creams and moisturizers since I was young. Just one case of a patchy ulcer in the tongue. So it was a grade 2 stomatitis, oral stomatitis, but overall the combination or the treatment is very well tolerated, so no problem.
That's good to hear.
We're also seeing that the sites are very compliant with the care kits that we're giving to the patients, and the patients are also very compliant. I think that it makes them feel like they're doing something for themselves, you know, that they can help themselves by putting these creams and moisturizers on, and they think that it's helping. So,
is that your experience in Poland, your patients on study?
2 patients in our site haven't had any adverse events yet.
So overall, the tolerance of any patient enrolled on trial seems to be pretty...
Only, I think, one time, neutropenia about one
in one course of one cycle?
Second grade, I think. Only one.
Oh, I see. Oh, okay, okay. And hard to tell if it's
I
chemo.
know that sometimes we are treated, but not in this medicine against the rash, against the wounds, against the bruise with anti-allergic, the prophylactic anti-allergic pills.
Like
It's
Benadryl,
then the patient is not rash, is not scar.
not itching,
skin,
yes,
and it's helped
yes.
a lot.
With
really.
Diphenhydramine or something like
Right.
this? Yeah, I see.
It's helped.
Okay,
As
helps.
prophylactic, we are giving as prophylactic these pills, and it's helped
Okay.
a lot. Not in this.
So I believe you all have the booklets that were created by Dr. Lacouture. And again, as Bruce mentioned earlier, the skin care, when I was practicing seeing patients, I'd be frank with you, I did not pay a lot of attention to skin care as a standard thing to do for my patients on chemotherapy. And so the trial just brings it, I think, to more attention that this is an important part of general patient management for any patient receiving cytotoxic or immunosuppressive therapies. And so number one is please to remember that dermatologic conditions you might see on this trial do not unblind the patient. It's not an automatic assumption because they have a skin rash of some sort or some problem that they're automatically getting study therapy, correct? So that's one thing, important point we wanted to bring up to your attention. With gemcitabine, there can be many different types of reactions, or this one quotes some mild edema in the skin. Again, this maculopapular rash occurs with gemcitabine. We have a brief video to show you that's, again, part of patient management. It is featuring Dr. Nora Boyer of Threshold Pharmaceuticals. So it's about a 7-minute video we'd just like to show you. It just reviews for you management of skin care toxicity.
So NSAID, I don't think that it's good. NSAID, it's good.
I'm sorry, say what is good?
The NSAID.
Oh, NSAIDs, non-steroidal
Non-steroidal
anti-inflammatories.
anti-inflammatory drugs. I don't think it's, you're sure it's good? You have
we're not recommending or not, have no experience with a systemic treatment for these skin.
Only for the pain. A pain due to the.
So your question is, can you use non-steroidal anti-inflammatories to treat symptoms pain for patients who are on the trial? Is that the question? No, that is the question?
It's not.
Are you?
I think it's not allowed, really.
Well, this is a great
This slide is showing
concomitant
something
myth.
different.
Yeah.
This slide is showing that patients who receive gemcitabine, 30% of them might have rash.
Related.
With doxorubicin, 80%, and even patients receiving antibiotics, non-steroidal anti-inflammatory drugs, analgesics, allopurinol, they may have rash because of them. This is not the medications to be used in case of rash.
Yes.
Right, yeah, thanks.
But do you want to answer that question?
No, yeah.
Are non-steroidal anti-inflammatories allowed
Exactly
as a
what we said.
concomitant med?
It's not whether it's allowed or not allowed, but it wouldn't do anything to the skin rash or not so much to the mucositis. So, but I just want to clarify that these are not the medications to treat skin adverse events.
So also, I just wanted to just mention, yeah, if you go back to that very first picture. This one? Nope. Yeah, that actually is a gemcitabine rash, okay? But you can potentially see a similar type of rash with TH302. And then the second picture is actually a patient that is on TH302, okay? He didn't follow the directions. The directions are not to go into hot tubs after you have your infusion. He went into a hot tub, and this is what he came out with, this rash. And the white, yeah, it is, the white blots on his chest are actually his fingers where he pushed in, and so you can actually see the extent of the rash. So another thing just to tell your patients, no hot tubs, avoid heated car seats, that type of thing.
Hello, my name
Merck KGaA, its affiliate in the U.S. is the sponsor of a phase 3 trial called Maestro, which is testing an investigational drug, TH302, in the treatment of advanced pancreatic carcinoma. During the Maestro study participants may experience side effects that include irritation of the skin, particularly in the genital and groin areas, as well as in the folds of the skin, such as under the breasts and in the armpits. To help study participants proactively manage these side effects, Merck KGaA and its U.S. affiliate, EMD Serono, and Threshold Pharmaceuticals have developed a patient care package. This video will review the products included in the patient care package and their use by the participants in the Maestro study. Each participant will also receive a handout with the care package, which outlines the items included, instructions for use, and tips for minimizing potential side effects. Please ensure you review these instructions with each study participant and ensure they understand how to use all 4 products. Participants should be encouraged to utilize all the products included as directed during their entire participation in the trial, whether or not they are experiencing these symptoms. Study participants should also be instructed to bring the care package with them to each study visit. The patient care package includes the following 4 products: Preparation H, Desitin, sunscreen, and petroleum jelly. In order to help you provide instructions to the study participants on how to use each product, we will walk you through the different uses and when to use them during participation in the Maestro study. Please note that comparable products may be substituted depending on where you are located. Preparation H is a topical ointment that is typically used in the treatment of hemorrhoids and inflammation. Preparation H contains an ingredient that causes vasoconstriction or a narrowing of the blood vessels. The purpose of Preparation H in this study is to minimize the circulation of study drug in areas where skin irritation could occur. During participation in the trial, Preparation H should be applied 15 minutes prior to each dosing of the study drug. The ointment should be applied to the patient's perineal area, around the anus, and under the armpits, and in any other area where skin surfaces are touching. To improve understanding and adherence, it may be necessary to review the anatomy of the perineal area with the participant. Discretion should be used on a case-by-case basis. Decidin is a topical cream ointment typically used in the treatment of diaper rash and similar skin irritations. This type of irritation is caused when the skin has prolonged exposure to moisture, skin chafing due to constant friction with clothes or folds of the skin, prolonged contact to urine or feces, and when skin is exposed to a dark and warm environment. During participation in the trial, Decidin should be applied twice daily to the genital and groin area and after each bowel movement. Sunscreen is a topical cream that, when applied to the skin, will help absorb or reflect some of the sun's ultraviolet radiation. This minimizes the skin's exposure to the sun, protecting from sunburn and associated irritation. During participation in the trial, sunscreen should be applied at least 30 minutes before sun exposure and should be applied to any exposed skin, including the face, ears, neck, arms, and hands. Also, when going out in the sun, study participants should be advised to wear protective clothing and wear a hat. Petroleum jelly is a topical ointment that has many different uses. Most often, this ointment is used to treat dry skin by preventing moisture loss and providing lubrication for conditions such as hemorrhoids. It is also used to protect minor cuts and burns. During participation in the trial, petroleum jelly should be applied twice daily or as needed to areas of dry skin. Study participants should also be advised to keep dry the areas where folds of skin touch, such as in the armpits, under the breasts, groin, and genital area. They should also be reminded to avoid vigorous washing and towel drying in these sensitive areas. We have just reviewed each of the 4 products included in the patient care package. There are additional useful tips to help minimize skin irritation and inflammation associated with the study drugs in the Maestro study. It would be helpful to also review the following tips with the participants at your site. Have the study participant chew on ice chips while the study drug is being infused. Have the study participant hold a cold gel pack between their legs in the groin area during study drug infusion as tolerated. Review key dietary suggestions such as incorporating foods that are rich in fiber, drinking plenty of fluids, and if necessary, taking a stool softener. These suggestions should help with digestion and ease up bowel movements. Encourage study participants not to sit for long periods of time without getting up and moving around. Advise the study participants to avoid all skin adhesives such as bandages, wearing tight-fitting clothing such as jeans and belts, spandex, tight-fitting shoes, or pantyhose. Wear very loose-fitting sports bras without elastic and loose cotton underwear. Finally, advise the study participant to avoid hot baths and showers, including hot tubs and whirlpools, for the 24 hours following study drug dosing. A full list of tips is included in the patient care package. Patient safety and quality of care must always come first. Careful review and training on the patient care package instructions can help to achieve this. It is up to us to provide trusted advice to ensure maximum comfort for each and every one of the participants in the Maestro study. If you have any questions related to the information provided in this video or about the Maestro study, please contact your local study representative. Thank you for your time.
Anything? Chiara, any questions, or do you think this is something the patients can do in the clinic? Ice pack, ice chips, lotions?
I like this kind of package for each patient.
To have everything for the patient?
Yeah, I think that will be useful
Yeah.
for a patient.
Yeah. And do you have ice at your site? Ice chips for the mouth?
No,
No.
no,
You have
No.
at your site.
I
No.
remember for 10 years, we gave them ice cream.
Ice cream,
No,
yeah.
ice cream, for,
Popsicles.
Popsicles.
Yeah, yeah.
for 24 hours, we suggested them when they're not sleeping, always
Oh,
take
wow.
it.
Yeah.
How about in Hungary and Poland, ice?
You have one patient, and she had a rash in her neck.
On the neck,
But it is a moderate,
Yeah.
not a severe.
yeah. Do you have ice? You can give ice cube, something cold? Nothing for the mouth, but no trouble.
But does your site have access to ice if you wanted to have the patients chew on ice? Do you have ice at your center? Yeah, okay. But you do not. You don't have an ice machine?
we have the ice, but we don't use it.
Don't use it yet?
No,
Okay.
no.
Okay.
We use ice sometimes, only for alopecia.
Would you?
Alopecia.
Yeah, yeah,
Oh, the cold caps.
yeah, yeah. But
Would you consider having the patient
But
chew on
not-
ice chips for Maestro?
okay, we can use it.
Yeah.
Yeah.
Okay.
Yeah.
To
Great.
prevent the mouth, yeah. And again, the rash does not unblind the patient, or any sort of like mucositis does not unblind the patient necessarily, so.
Is this video available everywhere, or is it just?
Yes, so Covance had, all the CRAs have this video. So they should be showing it at your initiation visit. And then if, upon request, if you want to see it again, certainly. Yep.
And then in the books, and then also I think at your SIV, there was probably instructional information given on how to manage various toxicities. And Dr. Boyer has certainly made herself available at any time if there are questions regarding how to manage some of these side effects on
Yes.
patients.
So one of the things we've done in the past, other sites have taken advantage of this. If you have a patient that's having a skin reaction and you want some quick advice, certainly send us an email. And Nora Boyer actually, I think, has a hotline right to Mario Lacator, particularly if it's a situation that you're not clear on how to treat. And Nora and Dr. Lacator will get right back to you. They're very responsive. The other thing I wanted to mention too is I believe this video is on our training website. So you should have access through Covance to www.maestrostudytraining.com. So it's maestrostudytraining.com. And there's the video should be loaded on that you can access right off the internet. Okay?
Okay, so I'm aware of the time, and I just wanted to go through a couple of cases, and then we'll get to some of the key questions at the end of the meeting. But let's look at, and the cases are perhaps all in different order in the booklet, but let's look at this case of a 40-year-old patient with metastatic disease. So this patient, 40 years old, father of 2 children, comes in with some weight loss, abdominal pain. For about a month, he is treated symptomatically for his symptoms. So no specific symptoms, but is managed for gastritis and reflux. Then he develops jaundice. He has a bilirubin now of 3.2, elevated AST, ALT, mildly anemic, creatinine 1.2. Here are some medications he's on for some mild respiratory issues. Endoscopy with EUS is performed. A stent is placed and a biopsy performed of a region in the head of the pancreas. Bilirubin after stent placement is 1.3. The biopsy returns showing evidence of pancreatic adenocarcinoma, and his 99 is elevated at 340. CAT scan is done. He has some small liver lesions consistent with metastatic disease. He's now at your clinic. Now it's about, a month, 2 months since he started having symptoms. He's lost 13 kilos in 3 months, has decreased appetite. His pain is preventing him from going to work, but through this other time, he has continued work. So again, 40-year-old patient, how are you managing this case? Dr. Pawlewski or Zaletsky, what do you think for this case? Why do you hand him the microphone?
Okay, in my opinion, the best option for this patient will be FOLFIRINOX.
And again, why
Yeah.
FOLFIRINOX and what basis? Yeah, yeah.
Yeah, just because he's young, first of
He's
all,
young.
40-year-old.
Yeah.
We know that FOLFIRINOX can give him about 11 months.
What do you classify his performance status to be? And again, there's no right or wrong answer. What you may judge to be one performance status, a colleague may say that's different, in my opinion. But just for discussion and interest. So this patient has basically weight loss, lost his appetite, and some pain for 2 weeks.
You have 2 children.
Yeah. So, Lidi, how do you evaluate performance status? I'm sorry?
Maestro, really?
Oh, you would think Maestro. Okay. What? How? Tell me how you assess his performance status.
He's young. He has 2 children, young children. He doesn't go to work. He's suffering from pain.
Yes.
He don't have any quality of life.
So, a Maestro says you must have
You will ask him,
Yeah.
the patient, 40 years old, what he prefer
Yeah.
to receive the FOLFIRINOX with all the side effects, really, and only the single agent, I know,
Is this- Is this an ECOG 0 to 1 patient, in your opinion? Is this ECOG 0 to 1?
I need to know how many times during the day he spent on sitting, laying, or
Yeah.
first of
Yeah.
all.
Yeah. So that would be a big factor for you in deciding.
Yeah.
So if he is spending more time down than up,
Yeah.
then maybe not a FOLFIRINOX candidate?
It could be disqualify him.
Because even he's young, that might be.
Yeah.
Yeah. Any thoughts? Dr. Crivellari, your thoughts on this case?
Sorry, FOLFIRINOX not so scary, I think.
Not so scary? Yeah. Yeah.
We have
No, you're right that the FOLFIRINOX in original version is very hard to accept, but modified all FOLFIRI, in my opinion, in my experience, is quite well tolerated. And so
I agree. I agree.
Okay, sorry. And in my opinion, if performance status pain and the clinical condition could permit, this man asked me the better choice I have. I think it's a FOLFIRINOX. And another, in my opinion, gemcitabine monochem or the combination in the Maestro trial every week, every 4 weeks. And FOLFIRINOX only 1 biweekly. So he can stay at home and work or stay with his sons or kid a lot of time. And not with a quite well quality of life, because I'm not scared about FOLFOXIRI or modified FOLFIRINOX.
If he were 10 years older, 50 years of age.
I think
same.
the same.
60.
No, 60.
You
Yes.
have privilege, really, I don't know, in our hospital, in our country, you have a big privilege to be in a trial for the patient. It's easier for them, we are doing everything for them, they have a cab with money, they receive the CT, we do it. You know how many energy the patient have.
So the patient knows what they are going to be doing each step, is what you're...
We treat them like a baby, really. You know, when I'm thinking about the patient, really. I'm thinking about my father, my mother, my friends. What is better for him?
So at your location,
FOLFIRINOX. Okay, how long they will survive for the gemcitabine? How long?
I hope 11 or 12 or more months.
have you seen that? 11,
Yes.
12 months?
Yes,
On
in my
FOLFIRINOX?
experience, yes.
Yeah.
We have not so long
Please.
survivors, but
On the other hand,
Yes, okay.
Cancer.
Yeah.
If I could treat Folfirinox, I could.
And why?
Because he's a young. I think the Folfirinox is well tolerated treatment.
Okay, so tolerance in your experience has been okay. And certainly the data, what's your interpretation? Is 4 months enough difference, or for nab-paclitaxel, 2.7 months?
So I think who can tell me what will be in the future? What will be in the future?
Sure. Nobody knows this, yeah, yeah. So you have what you have now.
We have to do everything.
Yeah, yeah. So in your opinion, everything is...
If he tolerated well this treatment.
Would you ever do a initial treatment thinking maybe second-line treatment?
So second line.
If, I mean, Lida just brought up, you know... Yes, so Lida just brought up patients on a clinical trial. That's the second line. So the point was just brought up, patients on a clinical study they know their calendar, they're followed very closely. Within 2 months, we will know if the patient is doing well or not on, let's say, a clinical study. Right? Most trials have you evaluate within that period of time. Is it reasonable now, 2014, to think of this approach first, for the first couple of months, and then maybe a second-line treatment if the patient has not responded? Is that a possibility in 2014? Don't know. Dr. Salim, you have...
I would agree the best shot is given the first time. I mean, a lot of its performance status may be pain-related. Pain needs to be controlled. Modified Folfirinox is what I would go for as well, first shot. The only other concern of not putting him in Mastro straight away is the randomization, and there is a chance that he may still end up receiving gemcitabine without TH3 or 4. So that is blinded, and I would never know that. So I would give modified Folfirinox first.
You know you're giving
yes,
that
a
type
definitive
of
therapy, which is thing. There is a 50% chance he would only receive gemcitabine with the Mastro study.
Yes.
And because he's young, I would go with modified Folfirinox. And
what's your opinion on second line, the role of second line in pancreas cancer 2014? We saw a slide on it earlier in the landscape.
Very few, the proportion is probably less than 30%, 20 to 30% who are fit enough to go to second-line chemotherapy.
Maintain their performance
status. And it depends on how close you monitor them. I mean, the longer the treatment holiday, they come back with a worse performance status and you're not able to salvage anything. Mm-hmm. So your second-line therapy is never going to be as aggressive as the first-line therapy. And a lot of times when they come back, they are unfit for any chemotherapy at all. A lot of
But these wouldn't be patients who have been on a holiday of treatment.
Not holiday, it depends on how often you monitor them.
Sure.
Sometimes the disease is very aggressive, comes back in 6 weeks, things change. Like you showed that chemoradiotherapy, 5 weeks, performance status changed.
Yeah, yeah. So are your patients followed differently? I don't mean that in a negative way or anything, but are they seen in a different schedule if they're on a clinical trial versus not on a clinical study at your center?
I mean, clinical trial is, of course, it's very protocol regimented study, but even otherwise we follow them. But the advantage of a clinical trial, as most studies have shown, is you are much more regimented. When there are holidays, you make up, and public holidays and all those things.
Yeah.
These things are not done wantedly when you do non-clinical trial, but these things happen.
Right, yeah. So, you know, what I'm hearing is a 40-year-old patient. Please, Dr.
One another thing. This is young man, and in the Maestro trial, he may receive only placebo with gemcitabine, and I would treat him by Folfirinox.
You would vote for Folfirinox also because predominantly of age? Being a younger patient, you had mentioned. Okay. And so what I'm hearing is a younger patient, certainly 40 years old, we all agree is young. This patient, certainly the first treatment most everyone is thinking of is FOLFIRINOX. And is there a reason my patient cannot get FOLFIRINOX? And then as the age increases, it becomes a different way. Is there a reason my patient, like, what are the reasons my patient would tolerate something aggressive versus something a little less toxic, perhaps? But age certainly is a big factor, it sounds like, for selecting the type of first-line treatment. And fitness goes in there somewhere, but it's still moving, it sounds like. So not selected just on the basis of fitness, per se. But this is interesting because young patients, we don't see too many young patients like this, fortunately, but what we're hearing today is certainly very much similar to what other investigators have expressed in terms of how they're using various regimens now. The other part of that, obviously, is also this performance status assessment. It's very subjective.
Sorry, the performance status here,
Yeah.
according to what is written here, it's very good. It's 0 to 1. Because, okay, he didn't go to work, he had a pain, he can receive treatment against the pain, and that's it. He doesn't have vomiting, he doesn't have appetite. Okay, he can receive something to treat him how to eat less things. So this is good.
Okay. So Dr. Perkowski mentioned, well, if the patient, though, is spending all his time lying on the sofa at home.
You have fatigue. You have your fatigue. You don't have fatigue.
Right, it's not written here, correct. Yeah. Yeah, which is you can treat. So hopefully there are symptoms.
Performance status for me, for patients with advanced cancer pancreas is very good.
Yeah, okay. Anyone disagree this patient have a worse performance status than a 1? No? Comments? No? Okay. Yeah. I think that's one of the factors is sometimes the 1 to 2 judgment sometimes is more difficult in the clinic. Let's do one other case. Actually, let's go back to this one. Oh, sorry. Let me pick a different one. Let's try this case. This is now a 72-year-old patient. This is from our colleagues in Hamburg. The patient presents with a T1N1 cancer originally in 2012. A moderate differentiated ductal adenocarcinoma of the pancreatic tail, has a pancreatectomy and adjuvant gemcitabine October 2012 to May 2013. MRI now and follow-up is clear, August 2013. But December now, there's no local recurrence, but the patient has new pulmonary lesions. So a question here of how many here, or are you comfortable, maybe Laszlo, I can ask you, are giving clinical trial therapy that is gemcitabine based in a patient who has received adjuvant gemcitabine in the past? Is that a level of comfort? She completed it in May 2013 and now it's December 2013. So it's beyond 6 months. Or would you count that as, that's 6 months? Month 5 to month 12, 7 months. Is this a treatment option to give gemcitabine again for metastatic disease?
I think gemcitabine is not a good treatment in this patient, but he's 72 years old.
What options would you look at?
This is the maybe good option, gemcitabine, in this case.
Because of age?
Age.
Yeah.
Only for the age.
Yeah, okay. Older, so not a FOLFIRINOX candidate?
Any data about the patient, I don't know exactly, but I think the gemcitabine is good.
So this would not be a FOLFIRINOX patient in your mind? Again, no right or wrong answer, just
he is a echo O2-1. We can treat
Yes.
for FOLFIRINOX.
You would still consider FOLFIRINOX in this patient first line? Yeah, okay. And Dr. Accrual, any comments or how you approach a case of 72 years old post-adjuvant gemcitabine?
Well, I obviously agree that there is a little bit of concern to retreat patient with the gemcitabine because she failed gemcitabine 7 months before. But otherwise, I don't think that FOLFIRINOX could be a good option in this patient because she has a disease which is not very aggressive. She has only lung metastasis, but no liver lesions. So we don't have very much hurry to treat her. So I will go for 5FU alone or the trial. I mean, I think that gemcitabine could be an option in this case. So
now
why
doesn't
not?
exclude her from taking part in that.
No.
So
I mean, the risk of neutropenia and diarrhea, grade 3 or 4, is much higher in elderly patients. So go straight forward to a combination chemotherapy. In this case, I think it's a little bit questionable, at least.
A little too much, maybe, for someone. You mentioned reference to some idea of the biology of disease may be different, depending on presentation.
Yeah, there are some data regarding this, but they are not so strong, so I don't want to comment on those data. But the longer is the PFS, and the less aggressive is the disease. So
the fact she went 7+ months.
She went surgery on September 2012.
Yeah.
And she had a recurrence after 13 months.
Yeah.
14 months.
So that's telling you biologically something, and you use that in your decision making as well. What if the patient were 52 or 42?
52, I will go for. I will go for another therapy. 52, I will go for FOLFIRINOX or gemcitabine plus nab-paclitaxel.
Or nab-paclitaxel.
Yeah.
And why that combination of choices?
Why?
Yeah. Not to put you on the spot.
Oh, because I don't want I don't want a 52-year-old patient go for a gemcitabine alone. It's a under treatment in my opinion.
And again, a trial.
Just to reply to the
chance.
colleague that I prefer to have 4.5 months of life than a taxi fare waived.
You understood. You prefer the statistical result on the trial versus more mild therapy, so to speak.
No, she said before we pay the cab to the patient when they enter a clinical trial, right?
Not that. I say it's easier for the patient.
Yes.
When they are in the trial, it's help them when you have a person 40 years old with 2 children that is not working, is not going to work. It will be easier for him when he will be in trial. But the first thing that you have to see is what benefit for the patient. Of course, if the patient has to live more 2, 3, 4, 5 years with children with other treatment, it's okay. But if the ranges when you are comparing the 2 trials, and one is 4, 5, 6 months more.
we are talking about pancreatic cancer. We don't have any trial that gives the patient 2, 3, 4 years.
Not years. I didn't understand.
Months. Months.
Months.
Yeah, yeah.
Okay.
I told you.
Do you think that
If you have a medicine that you give a patient and give you 4 or 5 years, I understand.
we don't have this medicine?
Understood.
Doesn't exist.
Now you have.
But you think that 5 months of median survival is not worth in pancreatic cancer?
I think it's good, but when you compare the quality of life and what the patient received from that to that, and sometimes when you're sitting with a patient, you show him. You can show him. You have what advantages and disadvantages.
Come on, if you're deaf, you're not. You don't have any quality of life. You don't have life at all. So,
I'm curious what patient prefer. What
Correct.
the patient prefer.
Yeah.
If he prefer worse quality of life or longer life.
And this is, again, something that, again, comes up commonly because all clinicians have their own way of either, identifying appropriate treatment for the patient or different ways to discuss options with patients. And we've heard many times, particularly in this setting, palliative setting with metastatic disease, where the options are there, but nothing rises to the top as, providing 5 years of survival. That you have, you have to,
decision.
yes, and clinicians are presenting.
You know that the research that was done for Serono compared to gemcitabine.
Yes, you're presenting them all the
Serono
options.
is better.
Yes.
So if
Yes.
the doctor is thinking,
Yes.
he's saying, why you are doing research?
Yes.
If the results are this is better than that.
Yes. And
So
we've
he's right.
heard, and I
But
think
when
certainly,
you compare all the situations.
correct, the pluses and the minuses,
then you have
yes,
things.
yes, yeah.
But
Which,
it's ethical issue.
yes,
Very big one.
it is very big, I agree, because every treatment, particularly studies have big, long, thick consent forms with every plus and every minus. And the standard treatment may be much less in terms of clearly laying out every single side effect. But we know there are side effects with everything. But I agree, every patient we have heard certainly is presented every option. And many times clinicians feel that it is the patient's choice to make that key decision because you're weighing toxicities and what is statistically a possibility in terms of benefit. So it is difficult to sometimes make a clear decision. Yeah. So hopefully this 72-year-old case may be more typical of the types of patients that you see in the clinic. Any other comments, or should we end here and one more case maybe? Or? Let's try one more case. Let's go back to, oh, here's some good ones. Should we just do these questions?
Yeah, let's do these.
Let's just go here and ask you this question. Now, I understand this phrase aggressive may not be the same interpretation as aggressive when we talk about these treatments in the US. So aggressive treatment usually is a patient wanting treatment that gives the best result, regardless of the side effects, right? So in this scenario for pancreas cancer in the US, a typical patient answer is, give me the most aggressive treatment, and the typical doctor reaction is FOLFIRINOX, because the statistical data says it gives you the best outcome, doesn't matter the side effect. That's the most aggressive treatment. Is this, what's your impression, Dr. Cavalieri, in terms of what is aggressive treatment? Is Maestro aggressive because it's a clinical trial or a combination?
For my definition, aggressive is for side effects.
It's for side effects,
yes,
okay. Toxicity equals more
yes,
aggressive treatment.
Yes, in my opinion, yes.
Okay. Not necessarily better because
no,
it is...
No.
Okay.
Because we have to consider the results of the studies, the statistical data, and everything. Aggressive for me is the toxicity.
Side effects, yeah. So do you consider, so Maestro would not be considered aggressive?
I can't remember the thrombocytopenia.
50, 57%.
Yes, it's not gemcitabine monocamio could, but such a percentage.
Yeah.
So if I can add something about the thrombocytopenia, this is what I wanted to say a few minutes ago, but we jump on something else. We have had the opportunity last DAVA meeting. We were with Nora Boyer that you saw on the video, okay? And a few weeks before this meeting, we had the opportunity to attend the Milano sarcoma meeting from the ERTC, and you know that we had formally a phase 3 study in soft tissue sarcoma. And I've had the opportunity to interview the KOL who have participated to this soft tissue sarcoma phase 3 study. And something which was very important to notice is that, in fact, they have experienced the same thrombocytopenia that we can experience here, because it's not gemcitabine, but it's doxorubicin, which is also very toxic for the bone marrow. And in fact, they have never observed any problems with the thrombocytopenia. Some things that we have to keep in mind also is that gemcitabine itself is toxic for thrombocytes. And probably this is a combination of that why we have such a level of thrombocytopenia. But in fact, in clinical setting, we don't have any side effect of this thrombocytopenia.
That's it? Okay. I was waiting for more.
It's a good comment. Thank you. But I think one of the points that you make is when you talk about aggressive therapy, you're thinking about side effects. And I think we all agree in this room that if you're giving full doses of fulveronoxin, that's probably the most aggressive set of toxicity you're going to get, right? And I think what Nora's trying to get at is we don't really know where Maestro is going to play out. We don't really know where TH302 plus gemcitabine is going to play out from an overall toxicity perspective in the phase 3, or an efficacy perspective. All we've got is randomized phase 2 data. So it's hard to answer the question. But we certainly would think a doublet would be more effective and probably more toxic than a single agent therapy, right? We don't really know where it is. That's the dilemma.
I think a better question then is, Maestro, do you consider it effective option for patients?
Yes, I consider effective option.
Effective treatment option.
Yes.
Yeah. Any other thoughts on that, or?
I mean, we're trying to find out if it's effective. That's the reason we're doing the study.
True. Yeah, yeah. Effective treatment option. That's true. Yeah.
We don't know.
Yeah.
Because what I heard, and these multiple times, is it's not that you don't believe in the promise and the hope of the phase 3 trial with the combination. It's that my default is gemcitabine alone, and I think I can do better than that with what's currently available. I mean, I heard that from our friends in Poland. I heard it from the UK. I heard it from Italy, and even Marazi from Hungary. I mean, that's really the issue, right? So, the only reason I bring that up is inherently we've got only about 8 months left in this trial, so we're going to get through this because there is the right patient, and then we'll have the answer. But I think in the future, and knowing what the sponsor did with this trial with a single agent, you're going to have to randomize to a doublet. I mean, to be potentially viable down the road. I think that's coming. So we'll see, right? We'll see.
Do you want to take over?
No,
Yeah, just move on.
No.
No. Yeah.
Well, you've answered most of them.
We've covered the rest, yeah, in the discussions today. So I think, consider second-line options for treatment. I think certainly that's come up, and it's come to certain people's clinic, it sounds like, where that's possible. Maybe, certainly not standard presently, but it's a possibility for some selected patients, maybe up to 30% who might be able to get there. We discussed a bit about defining performance status. It is quite variable from clinician to clinician, but we sort of touched on that a little bit. Tumor extent or biology, are there certain aspects of disease that maybe play a role in terms of, again, who's the right patient for the right kind of treatment? And then locally advanced disease, and how do we downstage, or how do we use that role or situation of therapy in patients, and are those patients possibly Maestro candidates as well, or do you use other types of therapy to try to address those patients in that clinical situation? but there's a difference certainly between downstaging with surgical intent and downstaging to treat or treating, I should say, a disease that's not resectable. And that's got to be a clear definition at the sites, I think, is what that's a summary of what I heard today. So you can correct me if that is not true. Hopefully that's accurate. So I'll let Mark finish.
Yeah, sounds good. And just know that we enjoy agreeing to disagree, right? So it doesn't have to be the right answer and one size fits all, because that's medicine, right? Medicine is obviously, you're taught, you're trained to learn from clinical medicine, but your judgment in the art of medicine is very important as well. I mean, each patient that comes in with pancreatic cancer, whether, as you said, it's a person who really needs to spend more quality time with their family, they're not working, or are they going to get an extra 2 or 3 months of life and it's not that great of quality, is a decision that you have to make. The only thing I didn't hear today, this is our fifth one in Europe, right? We've got 3 or 4 more. So please do encourage your colleagues to come. If you're able to come, if you've got a PI, sub-I, research nurse, coordinator that is interested, please encourage them to come as well. We're doing 2 more in London, 2 in Vienna, and then that rounds out the trial, and we should be done by the end of the year. But one thing that I didn't hear, which was very prolific in some of the other meetings, is what Nora touched on earlier, which is, are we going to be able to turn pancreatic cancer into a chronic disease, like other diseases, where you don't just think my best shot is my first shot, and that I've got the opportunity to use sequential therapy. So in some of the other discussions, we actually talked about FOLFIRINOX or a FOLFIRINOX light, if you will, in the second-line setting if the patient improved. Now again, difficult when your randomization arm is to gemcitabine alone, because you may not get that outcome. But that could be coming as you start using different doublets in the frontline setting, and you may be able to have other combinations in the second-line setting. The thing about Maestro, as I said, we've only got about 8 months left. We're on a run rate of 50 to 60 patients per month. The key is, if you don't use it in the frontline setting, you don't get to use it again, right? So you exhaust a frontline option that only has the ability to be used in that setting. You always are going to have second-line options. You can always go to commercially available drugs in the second-line setting, but you only really get that one shot first. So just something to think about as you make your treatment decisions. And then we're going to have the answers pretty soon here too. So I look forward to getting those answers and seeing the sarcoma data, Martin, next year, and then the pancreatic data as well. So let's go to a couple of questions here. And I realize that I am the one person keeping you behind leaving today. And I promised we'd be out before 5, so I think we will. So I want to modify these questions just a little bit, and I would just want to go around the room. So what have you learned from today's meeting that'll help you identify potential patients for the trial? Because we know not every patient is perfect, but what did you learn here today that will potentially help you identify patients? And then kind of bring that to the next level, which is, what is the right patient, at least in your mind, for this trial, right? We know which ones aren't, but which ones are? And then lastly, I think this is aggressive, knowing where we are. So can you enroll 4 patients, that's 1 every other month, over the next 8 months, right? Because it's April now, you have 8 more months in this year, and that's really the commitment we need to get it completed this year. So if you can answer those 2 questions, I think that's a great way to finish the day. And I'm actually going to start. I started with you in Italy, so I'm going to go over here and start with our friends in Israel. So, Lydia, what do you think about these 2 questions?
About the first question, you say before that you gave me some light to look at it, and it's good. This what is did.
Refreshing, new, or at least maybe you've heard the data before, but maybe a different way.
More than refreshing to see, due to all this conversation, the benefits. Yeah. Really. By myself talking, I realized something. Yeah. The second one, we have a problem, not only pancreas, but all of the diseases. You have some months that you have a lot of patients with GI, a lot of patients with pancreas, right? And sometimes you don't have anyone. It depends, yeah.
You do, you need your spurt. You need, it's true, especially this disease. They come in waves. We realize that.
You have summer, at the summer, I know that you don't have a lot of patients, right? Sometimes, kind of patients. In the winter, you have a lot of lungs. Yeah, you have some period of patients.
Don't take the same bus. Don't take the same bus.
Yeah.
Yeah, for but, is that it? No. So I think I understand. And it is, I think the real benefit of meetings like this is that you get to understand each other's point of view on how to treat the disease, and you do pick up little pearls of wisdom. And you know, we do these a lot of times, and this trial is a perfect example of when you have trials that go on for a long period of time, you see fatigue, right? You get to a point, and then there's different options, there's other things that you're thinking about. So we try to do this to make sure we don't have fatigue for the trial. And actually, I think it will finish stronger than it actually started, right?
It's a big benefit, I think it's a big benefit. It's not frontal lecture, it's conversation, and you hear other people, and it's very good.
Yeah.
Really.
Well, this is
Don't
one of the,
have it a lot.
yeah. Well, this is one of those meetings where I think we met our goal, which is we only talk half the time, which is hard for me. That's why I kept my mouth shut. So we tried to get you talking, which is what we look forward to.
So I just wanted to make sure we answered your initial concern, because when we first met this morning, you were very concerned about that patient with the higher performance status. Did we adequately address your concern on that? And
It didn't it didn't help me about this patient. I was very confused about it, and I felt very bad about it, because she signed on the informed consent, and after 1 week we have to take it.
right, it's never a good
And
thing.
I felt very bad
Yeah.
about it. But I think that we have more patients that we don't.
Great. Okay, thank you.
That you may not offer it to, that may have benefited well. That's good.
The biopsy question was answered. What type of biopsy tissue?
Yeah, it's okay.
Yeah.
I read it after that.
Well, Lydia, it's been good, nice having you here. Good questions, good thought-provoking discussion. I appreciate it. But I'm going to pick on your partner there, Galit, who's looking the other way. She's going, please don't call on me, please.
Galit is wonderful. She's the study coordinator
Yeah.
#1. She's doing
There you
all
go.
the work.
So, Galit, what did you learn? What did you pick up today that you think would help you when you go back to your practice?
Well, I think I've learned from everyone here. I mean, I'm not a medical doctor, so everything is it's new to me.
Yeah.
What was the skincare helpful?
Yes.
Yeah, it was helpful. Maybe I have just one question: why a PET CT is not available here in the study?
What is it? What was the question?
PET CT.
We can perform an MRI, but not a PET CT.
Ah, good question. PET CTs. Yeah.
Well, it's not excluded. The protocol just defines minimum requirements for imaging, yeah? And the minimum is, I think, CT, according to standard guidance. If you want to do more, that's up to you, yeah?
Instead of CT. She's saying if we can do instead of CT.
If there's a patient with
Yeah, here the problem is that, I mean, this is a registrational trial, so we need to follow current standards of care in imaging, and still CT is a standard of care here, so that's why.
Your patient has trouble with dye, allergy?
Yeah, we had a patient with
Oh, I see.
Okay, no, I mean, so MRI, is that an alternative option? No problem with that, yeah. If for whatever reason, for example, the patient doesn't tolerate CT contrast or what, so you wouldn't need to, you would alternatively do an MRI, that's also possible. Yeah. You just need to follow up then, all subsequent imagings also need to be an MRI then, of course.
And for the patients who would develop allergic reactions during the conduct of the study, RECIST criteria allow that with just CT without contrast is done. This is for patients who have developed this allergy already being into the study. So you can continue just without contrast. This is according to RESIST, yes.
Only continue. At the first we have to do with, and
No,
after that,
no, I say that the first scenario is what Martin described. If you have a patient and you know the patient is allergic, the better is to perform an MRI. But if you have a patient who is already on the study and been there 6 months, for example, and having CTs with contrast, if this subject develops allergy to the contrast, then you can continue performing CTs without the contrast. So it's a different scenario, just the same point.
Good, very good. Answer your question? Okay, all right. Dr. Perkowski, how about your thoughts on question number 1 and question number 2?
I think it's a very interesting meeting, especially interactive meeting. We can exchange our experiments, our thoughts. For me, the most interesting was about hypoxia mechanism and hypoxia mechanism growth.
Dr. Foxstock, yeah. Very good.
Yes, and despite that I prefer FOLFIRINOX, as you said, as I said.
That's okay. It's okay.
I'd like to notice that we randomized 4 patients.
Yeah. Well, you know, at the end of the day, you may prefer it, but you still found the right patient for this clinical trial.
So can you imagine if you didn't prefer FOLFIRINOX, how many patients we would have get into the trial?
We have more possibilities.
So the question is, can you put on another 4 patients in the next 8 months? You already did the first 4.
We do it. We will do it.
I think you'll do it. Yeah.
I know we can.
Yes, exactly.
Yes, we can.
we have confidence in you. Artur, how about your thoughts? What did you learn here today that you think would be helpful? And then I think your colleague spoke for you, so you're part of the team.
I also, before this meeting, know a little about hypoxia, but today I know a little bit more.
Yeah.
So I am very happy for that. We have 4 patients in this trial, and possible we would have another more.
Mm-hmm. Yeah, I think you've got 8 months. I think there's enough time. But the question is, even though you know more about hypoxia, which I think it's a wonderful presentation, how much do you use that with your patients when you're talking to them about the trial and the drug? How much is actually communicated, and how is it communicated to the patient? Or is it at all? I mean, you know, I'd be interested.
Do they ask? Do they ask about the mechanism of action of a therapy that they're going on in experimental?
No.
Okay.
Anybody else? Our colleagues over here, do you ever get asked, well, how does it work? You know, what's the way that this medicine works?
Did the patient ask us?
Yeah.
Yes, sometimes.
Some,
want to know.
yeah, some do, some don't, but it just depends.
Do you think if you explain the mechanism of action, it would make a difference in their consideration for the trial? No?
to see what we saw here, it's very frightening for people that don't know.
Right, right. And that's one of the reasons our legal group doesn't want to share the video. It's a little bit too much, yeah.
It depends. I mean, it's variable. Yeah, sometimes it's not the patients, it's maybe their son or their daughter who's done the internet web search and has a lot of questions to ask. And every patient is variable. Some are very scared, some want to know, but you can't generalize, I think.
Yeah. Well, and it depends on the patient, right? Because you may have a very highly educated patient, you may have a physician who's, you know, wants to know. And then you may have the ones that are just coming with you know, complete trust. Doctor, you're my doctor, you tell me what would you do, right? You get those types of patients as well. So it's a mix. Yeah, very good. Dr. Marazi, what are your thoughts on today?
I and my colleagues will enroll many patients, I hope 4 or more, and you have written the answer on this slide. This meeting helped identify patients.
Yeah. So you feel like you got some little pearls or identifiers to help you find the right patient for the trial. If it broadens your horizon and allows you to think about other patients that could potentially be eligible, that's really what we're looking at. And we didn't put the slam dunk patients up on the cases because this would be a very repetitious meeting if every patient was, yeah, well, Maestro, yeah, well, Maestro. We wanted the ones on the fringes because we expect you know the ones that you would normally put on. But what about the ones that are a little more difficult and you may have to ask a monitor? Constantine can answer your questions. You know, Dr. Martin Falk can answer your questions. Those are the ones where we wanted you to think about here too. Very good. Dr. Salim?
I think I enjoyed the discussions. There are a few points I have learned. The first thing is the general consensus in the way patients are treated across different centers seem very similar, although there are some discrepancies, but overall the thinking is very similar, the way you approach and treat patients. That's number one. The number 2 point, I also think the decision you have taken in treating patients with pancreatic tumors who have a high degree of hypoxia is actually a very good decision, because a lot of chemo agents have come in pancreatic, like FOLFIRINOX was not originally a pancreatic regimen, it was a regimen borrowed from somewhere else, but whereas you started with pancreatic tumors, I think is admirable thing. Whether it works or not, only time will tell, only this trial will answer. And the third thing, I had something I forgot. Yes, your issue of the chronic disease.
Yeah.
I think it would be really good if we can make pancreatic cancer into a chronic disease. I think that is what we all aim for.
Yeah.
And the more non-overlapping regimens we have, the better it is.
Yeah.
If we are having a same gemcitabine skeleton regimen, there's always a worry whether you treat with the same regimen because if they have relapsed. But if you have a Mastro and a FOLFIRINOX or whatever, it just allows you have more drugs in your toolbox to treat. So I think this is something we should aim for, whether it's going to happen within the next 5 years or, as you said, 20 years. Gemcitabine, we are still there. I don't know.
Yeah. Well, you know, it's so gemcitabine. The slide that Dr. Trohan showed there said 1997. That was when the article was published, I think, in New England Journal of Medicine. But it was approved in the United States in 1996. And you know, I look at diseases like ovarian cancer that are much more chronic diseases. But you have you have a tumor that's very sensitive to chemotherapy. Here, not so much. But there's got to be other ways, and you need more in your toolbox than just gemcitabine, right? So that's the hope, you know. And let's see what the combinations hold in the future. So you've already got 5 patients enrolled.
Would I enroll more? I hope so.
I got to believe 4 more are easily in your wheelhouse. I'm pretty sure.
So we would think so. So I mean.
Well, I appreciate it, Dr. Salim. Good information, good discussion. Dr. Accrual?
Yes, thank you very much for this very exciting meeting. And I have learned many things. First one is how much help our nurses could provide in the management of skin toxicity or to help patient to have less of this kind of side effects. Yeah. Second thing is that I still believe that the optimal candidate to the trial is the patient for which I consider gemcitabine alone a reasonable option. Mm-hmm. Third thing is that I don't believe that pancreatic cancer would be a chronic disease in
the near future.
In the near future, no, yeah. I don't believe this. Just because it's 25 up to 25% of patients have 2 chances. It means that 75% have only 1 chance of treatment, and if you have only 1 chance of treatment, this is not a chronic disease.
Yeah.
I mean, median survival is still 9 to 10 months. So, I think that before consider it a chronic disease, we should have more active treatments, mm-hmm. and the more active treatment we have, the more is the percentage of patients that go in second and third line. We have some patients in third line. Everyone has, I think. About
That's a good
enroll,
point.
yeah. About enrolling, yes, I think we have 5 patients enrolled, and I think that more or less we could enroll 4 to 5 more patients, especially a locally advanced patient in August when the surgeon
is on vacation.
Yes, he's on vacation.
That is a good one. That's right. Write that one down, Christine. That's good. We're banking on August, you guys. But that's a very good point. And I think, you know, a couple statements well said there. I think we are a ways from chronic disease, no doubt about it. I mean, it's even like lung cancer. You only get maybe 2 shots in those now, but I remember when you got 1. No one believed in maintenance. Second-line therapy was, you know, not that frequent. So it's going to take time, and it's going to take different mechanism of action, so we do need more drugs. But the default mechanism for this trial clearly is gemcitabine. If you're not comfortable using gemcitabine alone, you're going to have a hard time randomizing this trial, and it's finding the right patient that you are comfortable with gemcitabine alone. Now, that will change completely once the trial is positive. We hope it's positive, and you have that option commercially, right? Just as you have that option right now with nab-paclitaxel plus gemcitabine, at least in some countries. And the nice thing about these meetings that we like in Europe is that each country is different here. When you go to the US, it's one demographic for the whole country. Even though the states are somewhat independent, everything's approved or not approved. And so here we actually get to see the differences in treatment. And it's a lot more different approaches in Europe than it is in the United States as well. So Dr. Crivellari, tell us your thoughts and round us out here.
No, thank you very much for everybody, because I enjoyed the very interesting discussion with you and with colleagues. Very, very interesting. I agree with Martin and Giuseppe. The better candidate is the patient who can tolerate gemcitabine. And this is the last chance that I can offer something.
Exactly.
Yes. So, in my opinion, and in our center, I think that 4 or 5 patients in the next 6 months, I think it's quite reliable. Yes.
Well, amazing that you opened yesterday. Yes. So that's a good sign. You left your PI back there to go through all the training, right?
Yes. No, I was there.
And please do, send him or her, to some of our future workshops. All of these, as I said, will continue to occur over the next, I think, 3 or 4 months. We've got 4 more workshops, but nice having you here as well. So what I want to do now is actually show you one more video clip. Now, I give it about a 0% chance of working based on my experience of the first 2, but we are going to improvise. And this is a palindrome. Now, who knows what a palindrome is? What? Yeah, there you go. So, what is it?
A word that you can.
Yeah.
A word that you can read in the true sense.
Exactly. Same words, different different meaning, right? Same words, different meaning, played in a different direction, right?
I love the visual, though. That was great, because I think
that's it.
We understood that right away.
The investigational study drug is currently undergoing clinical research and has not been approved for use in the United States, Canada, Europe, or elsewhere. The investigational study drug has not been proved to be safe or effective, and any claims of safety and effectiveness can be made only after regulatory review of the research data and approval of the labeled claims. As someone with inoperable pancreatic cancer, I am helpless. I do not feel that there may be a chance for someone with this disease. I have limited treatment options now, but my doctors, family, and caregivers want to talk about the future. What future? I feel different. With such a diagnosis, it is inevitable that cancer will define me and consume my life. It is hard to believe that there may be possibilities. There may be possibilities. It is hard to believe that cancer will define me and consume my life. With such a diagnosis, it is inevitable that I feel different. What future? My doctors, family, and caregivers want to talk about the future. I have limited treatment options now, but there may be a chance for someone with this disease. I do not feel that I am helpless as someone with inoperable pancreatic cancer. Although the diagnosis of pancreatic cancer that is surgically untreatable can be devastating, it does not have to define one's life. The Maestro study provides eligible individuals with inoperable pancreatic cancer with an opportunity to participate in the clinical study of an investigational drug that may support advancing the treatment of this disease in the future. Specifically, this study evaluates the safety and effectiveness of an investigational study drug when combined with standard of care chemotherapy. The future can be meaningful. There are opportunities today that may change the way this disease is treated in the future. For information about the Maestro study, visit www.maestrostudy.com. Maestro, conducting pancreatic cancer clinical research for the future.
Very good. You like that? That's good. So what I'd like to do now is actually take you to the website, because there is a lot on that website, and really the majority of it is for clinicians, right? There are certain materials that are approved for your patients, but most of it's for you to keep you comfortable and keep you up to date with the information. And what I'll do is I'd like to have Bruce kind of give you a little overview of the website, just kind of on how to use it and what's on it.
Yep. So just to be clear, a disclaimer, this was developed for the United States, and we have approval through a central IRB in the United States for use. We have not received approval outside of the United States, although this is available on the public domain. So there's nothing that's preventing you from going on and looking at this, but as far as patients legally using it, it's not really available outside of the United States. But there is a lot of good information in here. Gregory, if you go back up to the top about the study, if you click on that, it tells you basic information about the study. Are you eligible? There's a very simple, I think 3-question questionnaire to find out high-level eligibility, and then if a patient is eligible based on the response that they get, then they can actually look for and search for sites that are closest to them by typing in their zip code. Also on here, we have information about clinical trials. They can download a brochure that talks about the Maestro study, but it also just a general participating in clinical study brochure for patients that may want more information on just what are clinical trials and what are they all about and what does it entail to participate. I think that's about it. We do track this on a monthly basis. It does get quite a bit of traffic in the United States. We haven't been able to actually track a metric that shows whether this actually helps us get patients into the study, but it's really about raising awareness about the trial that's out there for patients and ideally hoping to drive patients into the trial.
Now, Bruce, what about and I know it's not necessarily approved, but you've got a video here. And then is the palindrome here, or is that
yep,
on?
So you can download the palindrome video from this website. Yeah. So again, if you wanted to look at the video on your own, you could go to this website and download it from there.
Right.
Okay.
But the skin video that Nora Boyer does, that's comes out of Covance's training presentation.
That's actually on our other website, which is the maestrostudytraining.com.
Okay.
And if you don't have, if Covance hasn't provided you with a username and password for that, let us know, and we'll make sure that they resend that to you. Okay.
Yep. Very good. Okay. What time is it, Nora? Am I close? Hey, we're right on there. So we made our goal. Our goal is to be out in less than 5 hours. I think all of you, I really want to thank you for your time today, giving up your Friday, but also thank you for being an active and interactive group. Sometimes we don't get people who want to talk. That's hard. You know, we got to put little shockers on the chairs to get you going, lock the doors. But this has been a very interactive group, good discussion, and we really appreciate all your efforts in enrolling patients into the Maestro trial. And I'd like to let Bruce just say a couple closing words. Remember, I told you, he's the general. You know, he's the guy who tells me how we're supposed to do it and when we're doing it good or when we're doing it bad. But thanks for having us.
Since we're in Germany, I just want to say Dankeschön, right? Did I pronounce that correctly, Petra? Okay. So, as Mark said, every meeting is different. This has been a really good day today. Happy to hear that you've all learned something from each other through the discussions. We always learn something from you as well. So, we try to listen and bring back ideas, and again, to try to make your lives a little bit easier. So, again, thanks for your contribution and your participation in the trial. We really, really appreciate it.
Very good. And then one last thing before you leave, we're taking one group photo. So one group photo, you guys got to come up here. We're going to have it right. Well, actually, we should open up the windows for the group photo, don't you think? So give us 5 minutes. Let's group and enjoy Berlin if you're spending a little more time, and if not, you got to go. Oh, and Nora says make sure you fill out the evaluations. That always helps us do more meetings. Okay? Thank you.